Thank you very much. I'm going to be presenting on behalf of my team from Johannesburg today, from the National Institutes of Communicable Diseases and from Rahima Musa Mother and Child Hospital. And we are going to be presenting our data on HIV antibody detection in children who started antiretroviral treatment in infancy. Usually, standard screening HIV antibody tests, although they are an immune response to HIV, are usually considered diagnostic, so a test that's used to diagnose the presence of HIV. And it is not expected that these tests would usually revert to being negative once somebody is infected. However, in the pediatric field, for several years, there have been anecdotal reports of treated children who are known to be HIV infected, yet who have lost their HIV positive status over time. And this includes the Mississippi baby, who was HIV seropositive, was HIV seronegative, and as well as several other well-treated children who started therapy early. And in fact, this phenomenon has also caused clinical confusion in the clinical setting, where children who, in the process of disclosure, may want to retest themselves when they get into adolescence, and there are examples of children retesting and then they're antibody negative, and a whole nother set of issues come up in terms of discussing what that means. But epidemiologically, we don't really know what the frequency of this phenomenon is in a representative population within the clinical setting. So the purpose of our study was really to look at the frequency of negative HIV antibody test results in a well-defined clinical population of HIV-infected children who were suppressed on antiretroviral therapy. So we started with 104 HIV-infected children. All of these were children who had enrolled in our clinical trials in Johannesburg. They were all under 15 months of age when they started antiretroviral treatment. And then we looked at them at this point in time, and they're now 3 to 6 years of old. And we only took those children who were suppressed to less than 50 copies, currently on their antiretroviral treatment. And we tested them with a standard ELISA, the gene screen from Biorad. So essentially, we've got a retrospective cohort. We've got a cohort of children who started treatment when they were less than 15 months of age. They've been followed for 3 to 5 years, and then we're testing them now to look at their HIV antibody status. And we found that actually in this group of children who were an average of 8 months of age when they started treatment and who were currently suppressed on antiretroviral treatment, actually the frequency of being HIV antibody negative was reasonably uncommon. So we only had 7 who were either completely non-reactive on the assay or below the cutoff for being positive, which is what we're calling a very low level of HIV antibody, out of the 104 children. So it was actually quite rare. However, what was interesting was the 7 who were negative. And in these 7, their mean age of starting treatment was 3.7 months. And the oldest one, who had a negative antibody result, was 4.9 months. So we thought we would look in a little bit more detail at children who started treatment at an earlier age. Looking also at the optical density, so somewhat of a marker of the quantity of antibody there to some extent, semi-quantitative marker. In children who had started treatment less than 6 months of age, the average was 3.6. It's not really a real unit, optical density unit, compared to 4.7 in the children who started treatment at an older age. Yet another indication that we really should be looking very carefully at the age at starting treatment. So what we did then is we tested another batch of children from our cohorts. We added an additional 122 HIV-infected children. All of these children were also enrolled in the same clinical trials. But all of these were under 6 months of age when they started treatment. And similarly to the other group, they were now 3 to 6 years old. They were all suppressed, less than 50 copies, and we tested them with the same ELISA. Now in this group, the prevalence of being HIV antibody negative was very much higher. So in this group, we're seeing 21% having an HIV negative antibody test. And this group, all of them were less than 6 months of age when they started treatment, and the mean age was 3.9 months, ranging from the youngest child starting treatment at 3 weeks to the oldest child going up to 6.9 months. We then broke it down more finely by the age at when children started treatment, putting the two groups of children that we tested together. So in the children who were less than 1 month when they started treatment, and we had 19 of these children, it was just over 36% who actually were either negative on the antibody, who had test, or who had very, very low levels of HIV antibodies. And this was similar in the 2 months and the 3 months. So in this group, the children starting treatment less than 3 months of age, around 30% were testing HIV antibody negative. It dropped off really dramatically at 4, 5, and 6 months, where less than 5% of children are testing negative on the standard test. And then in the children who were 7 to 15 months of age, there was none of these children tested antibody negative. So from our data, it would appear that just over 30% of children are HIV antibody negative if treatment is started less than 3 months of age. This drops off very dramatically in the period 4 to 6 months of age, where less than 5% are HIV antibody negative, and we observed no children starting treatment older than 6 months of age who were HIV antibody negative at a later point. From a clinical point of view, I think it's really important to remember that using standard antibody tests, because they're so strongly associated with diagnosis, can really lead to confusion in the clinical setting. And one needs to be very cautious about talking about this, both with healthcare workers and with parents around the use of these tests in children. But these findings raise really interesting questions about the development of antibody responses and whether these antibody responses either affect or are some kind of marker for what's going on in the viral reservoir in these children. It's clear there's accumulating evidence of the importance and benefits of early antiretroviral therapy, and in thinking about those benefits, we also need to then move that into infant diagnosis programs, because infant diagnosis programs, as they're currently structured, are not identifying children early enough that they could reap the benefits of early treatment. And I'd just like to thank everybody who has helped with the study. Thank you.
Okay, this paper is now open for questions. I invite you to come to the mics.
Hi, Herman Leray, Faculty of Pharmacy in France. I know it's a very expensive test, but have you get the opportunity to verify the HIV negative babies were DNA HIV negative either?
Excuse me, I don't understand your question.
If the babies who were HIV negative, they were also DNA HIV negative?
No, these children were all tested PCR, a standard DNA PCR. They were HIV positive.
Okay.
Okay, next person.
Hello, thank you for your presentation. I'm Jill Sanders from Baylor in Lesotho. We've certainly seen this phenomenon as well, and I would just comment that it's even more prevalent using the rapid antibody test. The limit of detection on the ELISA is actually much more sensitive. We're reviewing our data now, but I would say that clinically, we've seen it even more commonly than you're describing. Thank you.
Yes, thank you for that, because I think that that's an experience of a number of people, and I think Antibody tests have been developed for the purpose of diagnosis, and now when we shift them in terms of trying to understand immune responses, not all the tests are created equal. So very important to be looking at the methodology for how these things are determined.
Okay, go ahead.
Thanks for an excellent presentation and a situation that we are facing in our country. Also, I'm Dr. Rivari from India. Basically, when we start children on antiretroviral therapy after a DNA PCR is detected with dried blood spot and whole blood spot, then 18 months antibody test, we have some 46 children whose antibody test is negative. And as per EID algorithm of WHO, you have to stop antiretroviral therapy in that. Presently, we have not stopped. We are continuing them on ART. But what is the protocol? How do we evaluate them, whether this was discordance or what was the reason for this antibody negativity? How do we move ahead? What test we do to confirm this, basically?
Well, I would be very concerned about stopping treatment in these children. I think we don't know what the clinical significance of the negative antibody test is, and certainly we would not use this as a basis to stop treatment in any of these children.
Okay, the last question.
Yes. Tina Monique James from World Vision International. There have been certain instances in countries, especially where there exist or persist health systems challenges, where medical personnel who even though they've been trained to initiate pediatric patients, still lack the efficacy and were hesitant to actually initiate those patients. Since now we're talking about initiating infants at an even earlier stage, were there any special initiatives adapted in these instances to get these infants initiated?
I think you raise a really important point about empowering the healthcare workers to treat children. I think that's a problem that many programs have experienced, where healthcare workers don't feel empowered to treat children, and so it's good that you bring it to our attention. I think newborn treatment is even more complex, and I don't have any magic solutions for you, and I think we're all going to have to work together on working with that, because I think newborn treatment, providing treatment in the neonatal period, is a whole new clinical challenge that's going to need to be addressed in the health service.
Thank you, Louise, for the very important presentation. My question is, clearly these children are still infected, we know that. So did you look with some more sensitive assays whether they still have an antibody response against HIV? Because we know that antibody response is probably very important together with antiretrovirals to keep the virus, undetectable or for the long-term prognosis. So I was wondering whether you did in vitro antibody production, or you are planning to do, or we're talking about the avidity, but it is something which is not a very strong assay for that. So I'd like if you can comment on this.
Yes, I think this is really just the tip of the iceberg in terms of understanding what's happening with HIV antibody responses. And as you mentioned, there are many methodologies which need to be looked at and try to apply. We have several plans of our own. The one assay which we did use was the CEDIA assay, which is an assay to test for low avidity antibodies commonly used in the setting of trying to pick up incident HIV infections. We found that all of the children who were negative on our standard screening test were actually positive on this particular assay, but the significance of that is a little bit unclear.
Okay, thank you very much, Louise.